Thank you, everybody, and welcome. The National Care Coordination Academy team is grateful for the energy that continues to exist around this initiative to assess and meet the needs of families, children, and youth across the country. In every quarter of this country, for every group defined by race, ethnicity, language, disability, status. This has been a challenging week for all of us, for our nation. And I want to share my own feeling that the work that we're doing inside this academy has to be redoubled. It adds depth to our charge, and I want to welcome you. My colleague, Meg Camo from the Boston University CMC Coin isn't able to be with us today, so I am sending her greetings along with you today as well. So thank you for making the time to join us. I hope that you can feel the energy that we continue to build upon together as we advance this work. Let's go to the next slide, please. Want to again begin by recognizing our partners as well as our funders at HRSA, Maternal Child Health Bureau, Michael Warren and Anna Maria Padlin, Marie Mann, Treby Brown, Sarah Beth McClellan. We're honored to be able to continue to advance this work of the maternal and child health Title V community, branching it out, making connections with Medicaid, thinking about sustainability and measurement. Let's go to the next slide. Heather?
Yes, I'll take this one. Welcome, everybody. Nice to have you back. Just wanted to go over a couple of housekeeping items. First, the meeting is being recorded. This initial session today will be recorded and posted on Open Pediatrics for you to view at a later time. Our breakouts and workshops will not be recorded. Please don't use speakerphone. Please also don't put us on hold if possible. If you are joining by phone, please make sure that you mute your phone, and everyone, if you could please mute your microphones. Please also rename yourself to include your state team name first. Example right here, we have Colorado _ Sally Smith. If you could please make sure that your names look just like this. Our chat will be moderated and we've had time designated for questions, so don't feel like you need to keep up with the chat. It's really great. We love that you put all of your comments and resources there, but we will moderate that for you and bring it to the group. And if you are using a phone, please make sure that you link your phone and your computer together. I think I told a couple of you I would sneak pictures of my son Thomas into our presentation. This is him now. He's 4 months old, the same age as the Academy. So he is excited to let you all know that we are now approved to offer social workers credit. So in addition, for continuing ed credit, we can offer to RNs and NPs, MDs, PAs, and now social workers. The process for requesting credit, you will put your information on the attendance Google Doc. Jessica will share that in the chat. We'll then have you complete the evaluation that we'll send out at the end of the day. You will then be sent a survey from Boston Children's CME department to complete. And you'll be given instructions for how to log into the Boston Children's Cloud CME account to view your transcript and print your certificates there. The directions for how to create your Cloud CME account will be sent to you from the CME department. And unfortunately, we're not able to backdate credit for social workers that had attended our previous events, but I'm very excited that going forward, we'll be able to offer you credit. So we are now introducing self-selecting breakout groups and workshops. I am hopeful this will work out nice. Jessica and Beth Lynn put a lot of work into this. I really appreciate everything that they do to support the Academy. If you look here, once the breakout rooms are launched, you should be able to go to the bottom of your screen. If you are running the most up-to-date version of Zoom, you'll select breakout rooms. At first, the workshop names will pop up and you will select the workshop that your team has been assigned to go to. And then at the end of the day, when we go to the team breakouts, you'll see your team name where you're able to select and join. Once the groups are done, you'll get a notification that we're closing the rooms, and you should click to return to the main session. Please make sure you return to the main session and don't leave the group as a whole. If you do, you will be able to come back in, but ideally, once you come after your breakout room, please come back and return to the main session for the next event. All right, I'll hand things back over to Rich to review our day.
Okay, thank you. And before I jump into this, I just want to make sure that we have at least one person asking how do they change their name. So I don't know whether if it's done more efficiently individually, or whether we should give up 30 seconds before I jump into the agenda to make that happen.
Yeah, I can jump into that. You should be able to right click on your own. If you see yourself in your own little Zoom window, if you right click on yourself, there should be an option that says rename, and then you can type it right in. If there's any other issues, I actually can't check the chat right now since I'm sharing my screen, but Jessica should be able to check the chat and respond to you.
Okay, that sounds good. And thank you for showing us Thomas Charles's progress. It's just wonderful and uplifting, and I'm thrilled to see all of the chats. I agree, he is adorable. All right, so here's how today is going to unfold, everyone. We are really, really excited to focus today in the plenary section, if you will, around tiering. The inspiration for this is that Heather and I have had almost innumerable questions about tiering, about tools, and how does tiering relate to stratification, and how does stratification relate to risk assessment and risk adjustment, et cetera. So in fact, the content today is really to bring everybody to the same place of an understanding of what is tiering, how do you do it, and then over the course of this afternoon and subsequent sessions that Jeff Schiff will be doing with the Sustainability Affinity Group and probably subsequent Academy sessions, thinking about this longitudinal arc from moving from tiering to stratification and measurement, stratification for resource allocation, risk adjustment of outcome measures, et cetera. So I want to begin with this foundational discussion today on tiering. So between 12:10 and 1:10, we will be having Dr. Stacy Cook, whom I will introduce in a moment. And then you will be asked to join the workshops. I think everybody except 2 teams has already self-selected. And Heather can let the 2 teams know that haven't signed up yet that you should be thinking about that. But the workshops will, one on adaptation and implementation of several of the care coordination and care integration tools, family engagement, engaging Medicaid, funding sustainability, and then the tiering risk stratification group. We'll then have a break, and then we will go into individual teams. So that those workshops, this will be the first time that the non-plenary portion of the Academy actually will have cross-team composition. And that is, we're trying really hard now to get folks to begin to work together across teams on some shared strategic priorities. Then we'll conclude the team breakout sessions. Those breakout sessions will be team specific, as I mentioned, and then we'll have closing remarks and next steps. So that is the agenda for today. Let's go to the next slide, please. And I have the absolute privilege and honor to briefly introduce a colleague, Dr. Stacy Cook. Born in Pittsburgh, attended medical school and residency here in Boston, and then following her residency training, worked at Boston Medical Center with Dr. Jack Maypole in complex care. Moved back to Pittsburgh and did primary care in Pittsburgh for 9 years total, the first 5 as a primary care provider and the last 5 in complex care. She actually founded the Complex Care Center Children's in Pittsburgh in 2017, and actually just recently moved back to Boston, where she is the medical director of our outpatient complex care service. So I want to make a couple of points before I ask Stacy to come to the virtual podium. One, I didn't invite her because she happens to be at Boston. Actually, much of what I know about Stacy goes back to her Pittsburgh experiences. People will, especially the Pennsylvania team, it will be important for you to appreciate the fact that Stacy's voice was often combined with Renee Turchi's voice to interact with the state Medicaid program on issues related to medical home, issues related to care coordination, et cetera. So it's that connection is going to be really, really important as Stacy speaks to each of our teams today. This is not intended to be an academic discussion of complex care, but I want you to derive the principles of what tiering is, what it looks like, how to do it, and whether you apply it to a community health center, whether you apply it to a delivery system, a Title V program, a Medicaid program. Those are some of the themes that I would like you to extract today. So without further ado, I am going to ask Stacy to take over. And Stacy, you have a very anxious audience to hear about your journey, your experience, and your wisdom. Welcome.
Thank you so much. This is such a privilege, and I'm really grateful for the opportunity. So thank you so much. And I really am not, I will never pretend to be an expert on this per se, but I just thought that what I could do is kind of couch what I understand about tiering and stratification with the experience that I had putting a clinic together, because I know implementation is very near and dear to everybody's hearts here. And so any feedback or suggestions or thoughts, please just feel free to, I love the collaboration aspect of complex care, and I would love to hear from any of you. So please, at any point, let me. Next slide. So the learning objectives were in the agenda, and really, again, just kind of to talk a little bit about how classification systems were developed. And I only really go through that, again, not as an expert, but just to kind of give you a sense of where I think they kind of fit in resource allocation and implementation strategies. And so just some special considerations that I found important when designing a medical home for children with complex needs or children and youth with special healthcare needs. And then thinking about new ways to classify. And this, I would love to brainstorm with any of you on this, if anybody has thoughts about it, because I think there's a lot of different and really cool things to do in the future and ways to go with this. Next slide. So no financial disclosures. So just kind of making sure we're on the same page, because much of what I experienced and the population that I worked with was the CMC side of things. So knowing that there is some difference in the terminology in the literature and the way that we communicate with each other when we're talking about children and youth with special healthcare needs versus children with medical complexity. The CYSHCN abbreviation is really more the broad-based. You're talking the largest catchment, the biggest net, and then the CMC side is really the kids that are really the most intensive, the highest utilizers, the sickest in the group. So they make up a little bit of a smaller proportion. So can everybody hear me? Sorry. Okay. So I just wanted to make sure we were all on the same page here. When I start talking about my population, I'm really referring to the CMC side of things. Next slide. So in the historical overview, it sounds like it's going in and out for a few people. I'm so sorry. Let me know, Heather, if it's an issue.
Yeah, this is, I think what might be helpful, actually, we did this before. If everyone turns off their video, that can kind of help with the bandwidth. And we just have Stacy leave her video on. That's been helpful in the past.
Okay.
Thank you, guys.
No problem. So the historical overview, I just put this up because I just want to really emphasize that we're kind of at the beginning, I think, of this process in terms of defining these categories and thinking about risk stratification. You know, it's really just in the 1960s, right, that the idea of a medical home came about. And you saw this massive amount of resources come into play, I think, really with the onset of the ACA. And so as the Children's Hospital Association and these larger national groups get together and pull databases together, we're really kind of able to do different things and see different things in terms of this population, both in the broader sense and even the more medically complicated. And so we're at the beginning of this, and I think that means that there's lots of things and lots to do. And I hope everybody, feels comfortable lending their voice to it. Next slide. So why do you classify? Why do we need to do it? I think when I take a step back and think about how we started our clinic, I really feel that if you're going to get an institutional buy-in for resources for this population, this very, very large overview of tiering and classifying allowed us to get a real handle on the population. I mean, it's just, it really allows for much better advocacy at the institutional level and saying this number of kids need our help. This is what they do, and this is how we can classify them. And I think at a very general level, it's absolutely essential, and it's really moved us forward, I think, in terms of developing and planning and implementing programs for these kids. And I also think it also really increases patient and family engagement within the institution and the community, because they can feel that we are thinking about them and trying to do better for them. I know a lot of the families have commented that they, especially those that have been around for a long time, that they're excited by the amount of attention that this population has gotten within institutions. And they're just excited to see that we're thinking about it and trying to do better. Next slide. So I just felt like I should put this out there. I know this, I'm sure many of you know this, but just the mechanics of identifying and validating classification systems, it took me a while to just draw this out myself and understand how people were coming up in the literature with the subpopulations or with the groupings that they were talking about. And so essentially what you have at the very 30,000 foot view of this is databases, Medicaid, billing claims from these large institutions coming together and then getting kind of recategorized and classified based on their ICD-10 and ICD-9 codes, depending on the year of the publication. And then a statistical analysis is kind of applied to start to put these kids into different groups. But I think the important piece of this slide is really, if you just think about it, is based on diagnosis. And all of us know that those doesn't necessarily tell the whole story. And so I think that it's important to keep in mind that at this very high level, right, stratification and classification for these kids is happening really at the diagnostic code level. But then what do we do in each individual clinic, I think is really up for a lot of great discussion at this point. Next slide. So the classification systems in 2011, the Center for Excellence on Quality Measures was charged with identifying a methodology to assess disparities. And in that, you saw a lot of work in this zone. And so in 2014, we saw the PMCA, the Pediatric Medical Complexity Algorithm, stratified things into these three main levels: complex chronic disease, non-complex chronic disease, and then those without chronic disease. And so this, I think, is a great way to really think about it, because, for providers or institutions that may not be familiar with our population, it's easy for them to necessarily think of type 1 diabetes who may have a medical home with an endocrinology. They may think that's a child that needs the same level of care coordination and medical home support as a kid with, encephalopathy and CP and global delays. And I think, as we all know, that actually can be very different, because there's so many global things that go into the latter example. And you have one very chronic, very serious disease that has a medical home that's providing services. And so functionally, how we treat those two kids in any institution can be really, really different. And so I think just kind of thinking about some of those examples and applying it, if you think about where they might fit into these three classifications, is really helpful in thinking about, well, this is great at the institutional level, but what does it do for me as we get down to kind of how I care for them in my clinic? Next slide.
Sorry, Stacey, just me. I think a lot of people are still having trouble with their audio. Can you try maybe to go a little closer to your mic?
I can. I'm pretty close.
Okay.
Do you want me to try to switch I mean, if you want to take a minute, I can try to switch computers.
I think maybe that might be helpful because a lot of people are having trouble or recommending if you have a headset potentially. I don't-
I don't know if the headset will work in this. Give me 1 second and I'll log on.
Okay, thank you so much.
Sure.
All right, just a few minutes, everybody. And as you will see now that there is a closed captioning being provided at the bottom. It's in live time, so it might not be completely accurate. But I think this is another good way to help just so we can make sure we can all hear everything. Thank you all for your patience. All right, if I knew we would have this pause.
Heather, can you hear me better now?
Yes, I can hear you. Let's see. How's everybody else?
How is that?
I think that's better.
That sounds fine to
Yes.
me.
Yeah, it's good.
Totally.
Okay.
All right.
You got
Awesome.
a-
Thank you so much.
No worries. Gotta love my Mac. Man, that was fast. Awesome. Sorry, I didn't mean to give a little Mac commercial in there. Okay, next slide. So the summary points really that I wanted to just hit home is that, you know, classification systems are really intended to identify large groups of populations. They really help drive policy. And I think they're really important in getting institutions to stand up and say, this is an important group of people that need our help. I think they're very helpful with mild, uncomplicated disease and even kind of making sure that population management can be applied to them, which is really great. And they can also integrate, you know, mental health and socioeconomic variables as well. And that, again, is also really awesome, I think, when you're trying to do large scale population health. Next slide. So I think the question always comes up, well, then how do you use this in practice? So you assume a proactive approach, like you get this database, you find out within your institution, who are these kids, you put them into these big buckets. And so that's great. The question becomes, though, whether you're trying to develop a new program or you're working within an established complex care or medical home system. I find that if you're starting something new and you build it, they will come. And then it's really, even though you have these great things in place and you have this population you want to target, once you open your doors, you can't necessarily determine what bucket they fit into right away. And I found that really, really challenging. So I think that when you're starting with new program development, while it's helpful to advocate in your health system for how much money you may need and how many patients might be at your upper limit, when you actually open the doors, it may be a little bit more difficult to find where they fit. And the other thing that is really important is that they may move around in those large buckets once they get there, especially if you're doing your job right. So I think that it really does create a little bit of a trickier scenario or structure for those people that are going into new programs. When you're in an established program, and I think because many of us are really just trying to do our best and see patients, when you think about kind of program management, then maybe you may be able to take your group and divide them up because you know who they are. And that is a little bit of a different thinking. And I'd be happy to talk more about that with anybody that has thoughts about it. But I do think it's a little bit challenging for anybody that's thinking about developing new program versus applying it to an already existing population. And then I think one of the things that I did want to just mention here, and I can talk a little bit more about it when I talk about the structure of the program we had in Pittsburgh, was continuity is so important for these kids. And so much of the discussion that we have in terms of medical home is really making people feel heard and making them feel that people know their kid. And so continuity becomes that kind of catchphrase. And because these populations and the stratification of these kids can be somewhat fluid, we sometimes, I think, let continuity drive where we see them and how we see them in a way that might not always be the best for them. And I want to talk more about that. But, can we think about developing shared missions amongst the providers within the medical home that will allow us to take different tiers of these kids or different strata of these kids and move them through the care coordination structures that are best for them, but have the patient not necessarily feel that they're getting jostled around. I think it's really hard. I do think it's possible. And I think that it really lends itself to looking a little bit more uniquely at the kind of ways to classify these kids on a more nuanced level than at this very big, very high level. Next slide. So let me tell you just a little bit about what we did in Pittsburgh. And again, this is just, I know it's one center, so it may not fit your institution or the things that you're thinking about, but just to give you a sense of what we did. Next slide. So the design of the clinic, we called it C3. My division chair really wanted a flashy name, so we got C3. We opened in July of 2017. As of now, they have over 700 unique patients. As of 1/1, where I kind of stopped collecting the data that I'll present in a second, there was about 605. So we started from 0 and in 3 years had 600, which was pretty awesome and exciting to see as in terms of service growth. We were physically located in the main campus of Children's Hospital of Pittsburgh, and we actually were in the clinic area that saw or that housed the physical med and rehab department, neurology, neurosurgery, genetics. It really allowed us to work physically close, which is unfortunately not the case right now for anybody, but physically close with the people that we were sharing the most kind of clinical overlap with. We offered, and I could talk about this for hours. We offered both PCP services and consultative services. And the breakdown of that was about 55% to 45%. I have lots that I could talk about in terms of providing PCP care. I learned a lot and was very humbled by this. So I will couch that for a minute or for any questions. But yes, that was a huge challenge for us. The acute care, sick and urgent care, we offered same day availability. And I think one of the things that was really important too, and it kept our no-show rate down, is that we were able to schedule the patient based on their next subspecialty visit. So if we saw them and then they were due to come back in 3 months, we looked to see when they were coming back to see, say, neurology. And then that's when we booked our appointment with them. We saw them for post-hospitalization, for ED follow-up, made those phone calls, did that outreach. They had to have 3 or more chronic medical conditions plus technology dependence. So that's why I say that this is really the CMC side of children and youth with special healthcare needs. Our staffing was, we had 1 full-time administrative assistant, 1 full-time lead nurse coordinator, 1 full-time nurse, 2 Medicaid-sponsored nurse coordinators from 2 of the Medicaid payers, 1 full-time social worker, and then 2.25 to 2.5 full FTEs of provider support. Next slide. So some of the patient and family-centered features, we gave them 24/7 access to one of the 4 on-call providers. And in general, the patients, I think, would tell you that they really had they were happy to talk to any one of us. That was the main point, is that just because they got 1 person on 1 weekend didn't mean that the treatment or the recommendations or the input would be fundamentally different than the next weekend when another provider was on. Same day and acute, as I talked about, we talked about scheduling adjacent to the subspecialty visits. We had really robust electronic communication. One of my favorite things was when we were designing the clinic, I was really, really particular about getting just one pager number and 1 phone number. I didn't want them to have to memorize a bunch of different numbers. And then as soon as we opened, all the patients were like, we really want an email. Okay, we can give you an email. So we had email, we had a CHP email, we had a patient portal, we had telemedicine. We would pretty much see or talk to them however they preferred. We also had weekly communication with our community PCPs. So Boston's a little bit similar too, and I don't know how it's structured across the country, but many of the smaller private practices had been kind of brought together in a corporate entity around Pittsburgh called Children's Community Pediatrics. I was able to, meet with them and regularly talk with the care coordinators there so that we were able to communicate pretty much weekly anytime a new referral would come in from one of their patients, and just to make sure we weren't overlapping resources and that we were providing support when we could. And that was a lot of fun. I think it was great. Next slide. So what was our care coordination structure? And this, again, I could give a whole afternoon talk about the iterations that we went through to determine how we should care coordinate. So we were able to hold one clinical session per week for our entire team to sit together and go through our patients. And this is where tiering and stratification became essential, because initially, when we didn't have very many patients, we would go through all of them. And then as we got more, we didn't have the time. And so these care coordination meetings would go from, 2.5 hours to 4 to 5 to people running out to the afternoon clinic. It was crazy. And so we really tried to figure out over time through very small PDSA cycles, what's working, what's making this most efficient, and what does our staff like? And so what we ended up settling on was an Epic generated list that we updated weekly or could refresh weekly. And we risk stratified our kids into the 4 categories that we felt were most important for us to be most proactive about. Because what we found is that there were some kids that we didn't really have to be super proactive about, but there were others that we had to be. And so the focus on the 4 categories for this particular part of our clinic was on the people that needed proactive management. And so the way that we stratified them was kids that we knew we were the PCP for. And in that group, we looked at all of their routine healthcare stuff. So labs, well visits, immunizations. Then the next group was actually kids that were either in the foster care system, were in state custody, or were at risk for state custody where we were discussing it. Then we put in kids that we were managing their feeds. So these were kids less than 3 that we were managing their feeds. And then the 4th category was what we called sick. So not terribly descriptive, but people that we classified as being active. So these were kids that had pulmonary hypertension, kids that were really kind of coming in and out of the hospital a lot. And we were still scratching our heads about them, right? Because we all know that we have those kids in our clinics. And so those were the 4 categories we made up, and they worked for us. And we had to manually assign them. It wasn't something we could get from an ICD-10 code. We couldn't get it from Medicaid billing data. We had to assign it. We were fortunate that because we started out with a low number, that we were able to do that over time. And so by the time we got to 600, people had all been labeled. But that poses a challenge when you're doing that manually. And then what we did with each 4 category was we would sort. I would look at all of the sick kids in 1 week with my care coordination group and say, who was seen, when were they seen last? And then who doesn't have a next visit? That's actually who we focused on. So kids that had a next visit scheduled with us, we probably didn't talk about unless there was something going on, but we focused more on the kids that weren't scheduled and why. And then we might go through the chart, we might talk. A lot of times other people in the group had talked to them and we didn't know. So that became really what we did to care coordinate. Next slide. So these were the tiers. I just kind of went through them. Feel free to ask any questions if you have. I do want to say that the PCP services were just way more difficult to provide than anticipated. We had so many kids because we offered consultative services. When they came, they said they didn't want us at the PCP, but then without telling us would switch. And we didn't know that. They told insurance, but they didn't tell us. And that became very difficult, at least the way Western Pennsylvania and the Children's Hospital system there runs their behind the scenes kind of insurance stuff. The PCP wasn't always designated very clearly in the electronic health record. I noticed the difference up here is a little different. So I'm sure it's different across the country, but I think that's a really key thing. If you have a good, valid way in your EHR of designating the PCP, even when there's changes that occur, then maybe you're fine. But if you don't, it makes it really hard to care coordinate. Next slide. So who were the clinical service partners? So this came up a lot. Everybody had envisioned when I pitched the clinic that we were going to have this just like utopia of clinical service partners and interdisciplinary care all physically there every day. And I think as many of you know, that's just impossible. So if we were going to run a nutrition clinic, right, we weren't going to be able to do that 5 days a week to have a nutritionist with us physically. And my worry with that is that it was going to lead to a situation where then our kids that we were managing their feeds were going to have to come, and we were going to restrict their availability to come to clinic, which was really kind of an antithesis to what we were trying to do. I wanted them to be able to come when they wanted to come. And I didn't want to say, well, because we're managing your feed, you have to see us on Wednesday afternoons because that's when nutrition is here. So what we tried instead, and which was really fun and it worked beautifully, was we did it all ad hoc. And we were able to form enough of the relationships within the institution that we were able to have it when we needed it. So if we knew that the kid who was really struggling nutritionally was coming in, I could page them and say, can you come down? As opposed to blocking out their clinical time and then not having kids show up. And so for me, I really thought that it was a more efficient way to provide this kind of interdisciplinary management. One of the things I'm just most proud of, and I was so excited to hear that they were still having these meetings. You know, once a month, we would even very proactively meet with behavioral health, neurology, and supportive care and go through all of the kids with neuroirritability and unstable neurologic disease. And then what we could do is identify kids that we would want supportive care, which was our palliative team in Pittsburgh, just so that's clear. They could come and join those visits. They actually also now have a fellow in our clinic. But just having the behavioral health input and input about medication changes, and we would get advice, like if they call and we're no better, what do we do? And so we were able to keep that in a grid, and they're still doing that now. And I think it's awesome. And it was a great way to bring in interdisciplinary communication and to work collaboratively. I loved it. Next slide. So our patient characteristics are here. I just wanted to throw them up there. You get a sense of kind of, there was an even distribution really amongst the ages. Male, we had a little bit of a male predominance actually. Western Pennsylvania isn't super diverse, so our primary language was English. Most of our patients were Caucasian. The diagnoses are pretty standard for this group. And then, you know, if anybody is familiar with Pennsylvania, you have a large metropolitan area in Pittsburgh, but then it gets rural really fast. Whereas for Dr. Turchi on the eastern side of the state, it's a little bit more urban suburban the farther you go out of Philadelphia, whereas Pittsburgh gets really rural really quickly. So we had a lot of patients that were coming from 1, 2, 3 hours away. I did used to have a map that I would put up in presentations to show people where we were drawing from. We had some from Southern New York, a ton from West Virginia, some from Ohio, but you know, Ohio has fabulous services. So we weren't necessarily taking a lot from Central Ohio with Nationwide and with Cincinnati being there. But a lot of the people that were still west of Harrisburg were still coming to us from Pennsylvania. Next slide.
I built in this quick little break just so we can take a look at the chat just to see if there's any comments or questions that have come in. Jessica, do you mind taking a look in there and seeing if we have anything?
No, I don't mind at all. I don't know if Rich, did you want to start with the important to consider point that you made around complex care?
Yeah, thank you, Jessica. To call attention to this, so the children with medical complexity versus children and youth with special health care needs, I want to make sure that all of our Academy participants do not hear this presentation as justification for medical homes sitting in academic medical centers, as I mentioned at the introduction. So the The performance measures, the outcomes, experience, utilization are identical, whether the children receive the care coordination in community-based settings, including federally qualified or community health centers or academic medical centers. But the elegant approach that Stacy is laying out has to do with matching resources to needs, number one. The second point that I'll raise, and then I'll give it back to you, Jessica, to go to some of the other really important points that have come up in the chat, are this. The tools are the same. The outcome measures are the same. How the work gets done, whether it's a community-based setting, an academic medical setting, the operational elements may be different, but the implications of interprofessional training, the implications for family engagement, the opportunity to do a needs and an asset assessment that formulates a shared plan of care are identical across settings. And then Jessica, back to you to pick up some of the other pearls in the chat, please.
Great, yeah.
Jessica, can I just make one comment to follow Rich there? That was, you're absolutely right, Dr. Antonelli. And I want to just say that's partly why I even put that slide in there about the interdisciplinary care. Like, you could do that virtually now. I mean, I think that was what would be awesome about it. We didn't have to actually physically have them there. So for sites that aren't necessarily immersed with all those subspecialties just walking around, I think you could absolutely still do it because you don't necessarily need that. I think there's ways to get around it. So I just wanted to put my 2 cents.
Yeah, and Stacy, let me riff on that because I know that there's at least one of our HRSA colleagues. So I and I hope all of the Academy folks, and in particular the families that are part of the Academy and those that we serve, HRSA was instrumental in getting funding out to the community under the CARES funding mechanism, looking at how virtual care actually adds to the value, quality, safety, and equity of care outcomes. And guess what population seems to be benefiting the most in the situation wrought by the pandemic? It is kids with special healthcare needs. It is those children with medical complexity. Families actually have a tool, a care plan that they can work with their care team. And Stacy, exactly right. Multidisciplinary team meetings to talk about complex care are actually more enabled with virtual care. So tip of the hat to HRSA for getting us some of those care funds. And we'll be talking about this later on as the Academy unfolds.
Great. So we had a couple of comments. One comment from Michael Weiss about perhaps there being a little more conversation on rising risk as well and identifying kids that are heading into quote unquote trouble before they get there. Then we had a question from Rhonda about tackling the transition process. Rhonda, did you want to say more about that to get an answer from Stacy?
Well, I was just wondering if, this is Rhonda, if, because you look like you have a substantial number, 12 and older, do you take responsibility for transition? Or I know as primary care provider for those children you would, but what about those that you're not? Do you have any process?
So Rhonda, I have never successfully transitioned any of my patients, actually. No, we struggled with that. And that I would say is one of the things that I would really like to see the program do in the future is get a much more substantial transition plan in place. What we had done, because it was a fairly young program, the truth is that we took all comers under 26 and we hadn't had anybody that needed to go. What made me feel bad, and I think something for us to all consider as a nationwide community, especially in the era of COVID, was some of the kids that got sick and were not able, the older kids that were unable to be admitted to the PICUs and would get transferred to adult in this kind of pandemic setting. It was such a terrible way for them to end up in the adult system without having been transitioned appropriately. And so, I really started thinking a lot more about how we could do that better. We had adult providers that we would work with, but we did not have any of our major players that had become of age that needed to move on that didn't already have an adult PCP. So that I think is a real area of growth for them in Pittsburgh as they go forward, is to really kind of establish that. Insurance becomes a huge barrier for a lot of our kids, unfortunately, in Western Pennsylvania.
And sorry, Stacy, there was also a request from Meg Tracy to review options that were described to patients and families, and whether they opted in to the one they were eligible for based on stratification, or if or to one that they preferred. And she says, great info and thank you.
So I think you're meaning PCP versus consultation. Is that right, Meg?
Yes.
Yeah. So what we presented to them is that we were only there to provide, I used to say the language very clearly, I am not here to make your life harder. I'm here to help. And so if you would like us to be your primary care and you would like to do your well care here at the main campus, we'll do that for you. If you would rather stay with the PCP that is taking care of all of your other children and you have been with forever and ever, that is totally fine. We're here to help you and help them. And so, that's kind of how we presented it to them. And I never wanted them to feel pressured. So I always told them, and this came back to hurt us, that it was up to them to think about and then make that decision. On what had happened over time, depending on how active they were, is that if we became more of the acute managers, sometimes the family, without saying much, would say, oh yeah, I was talking to our care coordinator at the PCP's office, and they said we should just make you the PCP. And then I would say, when was that? And I'd find out that was 6 months prior. And here I was, I hadn't really done routine healthcare for them, because my understanding when they first came in is that they had a PCP. And the only way that it was designated was in the insurance, at the insurance level, which doesn't give me an updated list. And so just logistically, it became really difficult. So we wanted it to be patient driven at the end of the day. I never wanted it to be anything other than that. And it was really important to me that the PCPs did not feel that we were poaching their families from them. That was never our intention. We really, when I said that we wanted to help the families, we also wanted to help the PCPs. I don't know if that helps with the question, but that's how it was presented to them. And then it was their decision where they would go.
Got the thumbs up from Meg.
Yeah. Stacy, it's Meg. I just, in terms of rural families particularly, are there any situations where we have two PCPs? We have so many families who have access to a PCP, like through our community health center, and that person rotates. They're just basically doing like a placement there for 2 years, let's say. Are there any situations where you're actually saying we're the ongoing long-term, but we have an on-site kind of relationship? Sorry.
Yeah, for the rural families, here was the thing. What I used to tell them is that if you're physically coming into the main campus on a regular basis, we probably can handle it if that's what you want. If they're not, like if they were getting a lot of care at a satellite, we usually encourage them, if they were truly rural, to have someone out on site. Yeah, because it became an issue. Everybody says, oh, it's fine, I'll come. But then what would happen is we would go for a very long time, and it was hard to get them physically to come in. And I really didn't feel that it was fair to them to physically make them come to Pittsburgh when they weren't supposed to. But if they were coming regularly for other things, then it was fine. Like for our GJ tube kids, they would often get their GJs changed every 3 months. So we knew that there was at least a mechanism for them to physically be seen, and that we could manage probably what we needed to manage in the in-between time remotely, which was all pre-COVID, really. It's kind of fun, not fun, but it showed us that we weren't crazy, because we thought we might have been. People thought it was insane that we would sometimes do as much as we did without making them come in. But look at what we've all been able to accomplish during this time. So,
Stacy, thank you so much. I'm just going to jump in. I think we'll go back to the presentation now, if that's okay, and then we have some more time built in at the end for additional questions and comments from the chat. If we have more time. Again, as always, I will try to get questions answered after the day as well. Stacy, I think you're open. Potentially, I could reach out to you if there was additional questions that came up, and I can field back responses to people. Thank you.
Absolutely. And I'll just try to keep things brief as we go through the data so that we don't get too caught up in that. So just the presentation of the data, this is all encounters that were post-enrollment. So up to 24 months after they started with us, I included face-to-face and non-face-to-face encounters. When I say PCMH visits, those are the visits to the complex care center. It was just the ways that I was moving the data around. And then when you'll see something called care coordination encounters, that includes letters, DME orders, and informational encounters in the EPIC system. And that's usually what our care coordinators and a lot of the surrounding PCP care coordinators used when they were kind of entering in a quick note about something that they did for the patient. So next slide. So this is our hospital-based utilization. I am not going to go through the numbers. The main thing to focus on is that everything goes down. So they come to us at a point of high utilization, and in some of the preliminary work that I've been doing with my director here, Jay Berry, and his contacts at the Children's Hospital Association, it sounds like this is kind of consistent with what some of everybody else is seeing too, that they will often enroll in a medical home or a complex care center at the time when things are really active. And then through time, right, through care coordination, you start to see everything kind of trend downward. Our hospitalizations were pretty remarkably, they trend down very, it was unbelievable, to the point where we ran the hospitalization data many times. The ER data, which is by the red, goes up and down, as you would imagine. There's episodes that are high utilizing and times when it's not as much, but the overall trend is down. Blue signifies the subspecialty visits, which just for those of you that are trying to advocate within your own health systems, you know, what we kind of sold to our institution was, look, let us do this. We're going to decrease your need for these follow-up subspecialty visits and let your subspecialists see new patients, which are more lucrative to them and allows for better access within your healthcare system. And I think that the data definitely supported that, you know, because we could say, hey, you know, you're on levothyroxine, you've been stable, we withdrew your TFTs. Do you really need to go back to endo in 3 months? No, why don't we make it a year? And then that would kind of decrease all of that volume of follow-up that really was put into place because they didn't know if anybody else was looking. And that was kind of my point there. So next slide. This is face-to-face outpatient utilization. So, oh, I apologize. I think I had procedures on the first one, but this one has the subspecialty visits, which are in green, and you can see that down. What I think it does show, though, these are kids that aren't just like falling out of engagement with the healthcare system, because when you look at our encounter information, it's steady. Same with radiology. It goes down a little bit, but they're getting their chest x-rays, they're getting their annual spine films. I mean, they're still doing those things. It's just not, hopefully, the high cost emergency type ones. I can't say that for sure, but that's what I hope. Next slide. Here's our non-face-to-face utilization. I thought this was kind of interesting too. Refill encounters actually go down a little bit. Why is that? I don't know. I think we tried to get meds off that didn't need to be there. And we often were really just the facilitators of communication about that. You know, mom doesn't really think that the gabapentin's working. Can we start to wean? Okay, we can, we take it off. It wasn't something that felt overwhelming, but I think when you look at the data, the encounters for the refills go down. And I think that has to do with just getting the meds off, but we would have to go into that data more to prove that. Telephone encounters go down. And this, I believe, was important because I think if you answer those calls in a timely way and you get what they need to be done first, then I think you're in a situation where they don't have to call as much. And that's my personal opinion about that. And I know that people might have other opinions, so I'm open. But the care coordination encounters, again, they stayed kind of steady. And that tells us that they're still engaging with healthcare. They're just not doing it in an emergent or high cost way. And that's our hope that what we're seeing. Next slide. So some of the conclusions from the data, everybody was most active in the first 6 months. All healthcare encounters really decreased. They enrolled when they were in crisis. So they are a very high needs group in the first 6 months, but no single diagnosis protected need. Of the things that we thought were most important, like let's say you were gonna stratify or classify, right? NICU discharges were incredibly heavy lifts for us. Especially our time, many of our NICU babies, when they would leave the NICU, because they came from rural places to Pittsburgh, they would often insist upon using their PCP for everything. And that was fine. I mean, we can't force them to come to us, right? So most of our average time to enrollment with us from a NICU discharge was anywhere between 4 and 6 months post-discharge. So we were less successful than I thought about getting them to come to us right away. I just couldn't get a lot of buy-in. I even would go up physically and introduce myself, and I just kind of felt like I was selling encyclopedias or something. And most people were like, no, we're fine. We know this physician, we know this practice, they're fine. And then often they would end up coming back for hospitalizations and whatnot, and then they would come back to us. There was a lot to do there. Oral gastrotomy feeders, so kids that are in the middle, lots of work. And then I actually found that respiratory insufficiency without the trach was one of the bigger and most unstable kids, because you didn't have the opportunity to do as much pulmonary toileting, and we didn't quite know where they fit. They were kids that were on oxygen, that had lots of admissions for respiratory, were not trached yet, and we just weren't really sure where they were. So I think there was a question before about like trying to grab them before they get sick. Those kids always kept me up at night because I just didn't know where we were headed. Next slide. So some operational take-home points 3 years on. Proactive approach was really difficult. I just kind of mentioned, my goodness, like the NICU outreach was so much harder than I thought it would be. We actually looked very informally at patients we went to see inpatient when they were referred to us, and talked to them and gave them our card and just tried to tell them to come and see us, versus patients that were referred and we called on the phone, and there was no difference. So I had a harder time selling even in person than I thought I would. And so I think the referrals probably should just be patient driven. I think that's really important. We try to tell that to providers a lot. I would sometimes, even within my own primary care practice in Pittsburgh, would have a PCP say from our academic practice, I want this patient to come to you. And I know it would get frustrating, but I'd say, did you talk to them? Like, you have to talk to them, because if they don't want to come, we can't make them come. And so I think we were better off with patient-driven kind of enrollments. I think it's really, really hard to teach some of the families that have older kids how to engage in a different system. And we had to be patient. We had to understand that they have, for many, many years, 20 plus years, gone to the ER and gotten Augmentin to prevent pneumonia. There may not be a lot of clinical backing for that, but that's what they do. We had to be patient with it, and we had to earn trust. Otherwise, we were not going to change utilization patterns. And some of the preliminary data shows that the kids over 12, we had much less of an impact on emergency room visits than we did on all the other age groups. I think flexibility is key. You got to do what your patients want. If they don't want the portal, ours weren't super excited about our portal. They loved our email, and that's what we used. And then I really, really think responsiveness is essential. My colleague, next slide, had a great, I don't even know that she likes baseball, but you have to hit a walk-off home run, right? Even make it a grand slam, right? That first visit, if you tell them you're going to call their home PT and write the script for that, and then hook them up with the nutritionist there, then you have to do it. You can't just say it and then not do it. They are so used to that happening that they can't take it anymore. And they're just going to classify you and stratify you as a provider in that same bucket of people that told them they were going to do something but never did it. And so I just think it's really, really important to be as just hit it out of the park first time. You know, they'll give you more leeway later on, but not in the beginning. Next slide. So suggestions. I think when you're trying to allocate resources in any academic, non-academic center, community health center, wherever it is, I found that the new patients took the most work. I think NICU discharges, if you're really specifically in pediatrics, I think are an important group. I think kids planning to transition to or trying to transition to oral feeding are very, very active. Neuroirritability and sleep disturbance is one of the things I think that it really takes so much out of our families, and it needs a lot of attention. I talked a bit about respiratory insufficiency and oxygen without a trach. And then I think rare, rapidly changing disease. We had a case of juvenile Huntington's that was just changing on us rapidly. And it was absolutely essential to be involved with palliative care on that. because the baton needed to be passed at various points. And I think that's just critical. Next slide. So future directions, I would love to do this with anybody that's interested, looking into develop like a healthcare utilization index as a way of really kind of looking more nuanced at your population. Now you have these big buckets, you know who in your entire institution is someone you should look at, but now in your medical home, who are the people that need or require more follow-up or more proactive management? Because you can't really do it for everybody. It's impossible. The numbers are too big. And so one of the things I've just been kind of talking about with people here is like, can we make some sort of a rubric or some sort of an algorithm that we can use? And the reason I think this is important, because when you get to the extremes of utilization, what I found was, you know, my highest utilizers for ER and hospitalizations are kids that had to come to the ER and had to go to the hospital. So I'm not necessarily going to be able to make a huge impact on them. What I kind of want to know are the kids that are coming in but don't call before they come in. And they may or may not be the sickest of the group. And like, is there a way for us to figure that out mathematically and manage them within our population in a more streamlined and effective way? Next slide. So one of the thoughts I've had, and I've thought a ton about this, because as we got towards 500 patients in our clinic, the question came up, how many more can you take? And I thought, well, now what do I do? I feel good about the system we have for this 500, but do we create another team? And then how does the other team interface with this team? And are they really going to be separate? And then what happens when they get admitted? And what happens for call? My brain would just start to spin. And one of the things that I thought might work better, and this is totally a new idea, I don't know if anybody else would agree with it that's had experience, but one thought I had was, instead of creating two separate teams that had continuity, was to think about taking your new referrals and your classified tiering or stratifications that you have that are unique to your population, and creating an acute team that has really intensive nurse patient coverage with provider, with a social worker, with behavioral health if needed. And you just really get them together. And then the patient may not see any of this, but then you transition them to a more longitudinal team with nurse coordinators that can handle a larger population, because the frequency and the needs just not as great. That's just one thought I had. Next slide. So I just have to acknowledge there's so many people, but I have to say to our parents and patients, this patient and is a great example of utilization. So this is a 16-year-old. She was a victim of non-accidental trauma when she was an infant. So she had, you know, a TBI and had, you know, CP and global delay, but was a kid that I saw back when I first moved to Pittsburgh. I saw her in primary care, saw her once a year. She was great. Mom had my number, but never used it. And 7 years into my care for her, she started coming in, and I would never have predicted it. She had very symptomatic hypothermia, ended up having to get a G-tube. Ultimately, she ended up diagnosed with Shapiro syndrome, right? So something bizarre. She's doing fine. She's doing well now. But she went from 0 hospital admissions, no G-tube, to in 12 months time having 7 admissions. Her total hospital days were well over 150. And I would never have been able to predict that. And I think that's what makes it so difficult sometimes when we are thinking about how to be proactive with this population. It's almost like we have to be ready. We have to have a system that's set up and ready to scoop these kids up and be there for them when they come out of nowhere. Next slide. And that's just the references I use to kind of put some of this together. But thank you guys so much for listening. I appreciate it.
Casey, that was amazing. Thank you so much. I think we will have about 4 minutes for questions and discussions. I apologize for our tight schedule, but we can maybe look at the chat and, you know, take 1 or 2 questions.
Yeah, so so there was just I'm going to go in order. So was there family involvement as the C3 was being developed, and or is there family partnering at the clinic level in place?
No, it's a weakness. We needed to do more of that. That was on our agenda. We had informal family partnering. We had done some family-based sessions to talk about notes, to talk about clinic, but we did not have a family advisory council, and we desperately needed one. So that was definitely something we needed to do better on, without question. We did the FCCA qualitative survey in our group, and it was really helpful for pointing out some of those things. We needed to do better with family engagement. We needed to do better with, I think, just kind of assessing big picture community resources for the families. I think we could have done, we were so focused on the medical that I think we could have done more in terms of hooking our families up with some of the more psychosocial resources and community structures that were available. And we weren't as good about that as we could have been.
Great. Now we also have a question about funding. Scrolling back up to find it. How are you funded? What percentage of your budget came from FFS billing?
So this is interesting. My understanding is that Western Pennsylvania was headed towards a shared risk. At the time, though, it was really pretty much all fee for service. I mean, we just billed at a high level for established patients or new patients, just based on level of service. And my understanding is that everything was still being reimbursed fee for service, but I do believe that is in transition, and I'm not exactly sure nuanced wise how much of some of that may have started to change because it was fluid. The institution put up the money for me, for the advanced practice provider and the nurses. But we did, like I said, get outside funding for the nurse coordinators and the social worker. So it really was lovely because it gave us an inside track to our two largest Medicaid payers. So we did very little arguing. There was very little, I didn't spend a lot of time on prior auths. I didn't spend a lot of time on any of that. We had someone from the program that was in our clinic, and I could say to our nurse coordinator, so-and-so hasn't gotten this med yet. Do you know if there's a holdup? And they would take care of it. They could talk to someone in pharmacy, they'd figure out what the issue was, they'd get the forms faxed, and it was done. It was awesome. So aside from providing us more staff, it was really awesome. It made care coordination a lot easier.
Okay, I'm going to skip down to, Rebecca Griffin says, excellent presentation. Thank you for sharing the overview of the program and all of your great work. We also had a question about how have these efforts benefited patients who have been infected by COVID-19? So maybe we can end with that one before we move on.
Well, I think, to be honest with you, I think that we were set up for COVID. I mean, we had to do a lot of scrambling just like everybody else, but we had such good communication with everybody. What I think I was most proud of as I transitioned up here is that we didn't really lose sight of anybody, because we had already been talking to so many of them in a telemed type way, whether it was email or phone calls or whatnot. So I felt like we still knew who our kids were. And that was really important, because I think it was hard on a lot of big practices, especially our academic primary care center, the drop off and you didn't know who you weren't seeing anymore. So I think from a COVID standpoint, I don't know that it impacted their interface with us. I really do worry though, because we're doing so much. We're starting to settle into the well, now we haven't had a wait, right? Now we're not sure if the braces fit. There's a lot of things that I think are going to start to kind of creep up. I don't know if we know the full impact from a negative standpoint yet. But for us, at least when COVID hit, we had maintained our volume within 2 weeks. There was a dip as we kind of got our act together, and then everything was about the same.
Thank you so much.
Heather,
Rich, go ahead.
Heather, can I weigh in on this, because it's going to be really important, not just as we move into the small groups, but as I mentioned in the intro, today's discussion is to get everybody to a relatively common foundational space. And so this will be a recurring theme through the Academy in at least the next couple of months, including some deep dive attention with Jeff Schiff with the next Sustainability Affinity group. But there's a couple points in the chat that I specifically want to call out to continue to cultivate people's thinking. Rhonda, Katie talked about, you know, when when kids don't come in, the broader institution loses revenue. And that's absolutely a big problem in a strictly fee-for-service environment. And for care coordination, and Stacy Cook, kudos to you and for everybody else in the Academy. They actually are formulating what is a care coordination encounter. And let's not just call that's what you do 8 o'clock from your living room after you've done all of the face-to-face fee-for-service billings. So one of the rigorous components of the Academy is to teach you the skills of value capture. It's not surprising that you'll see some reduction in old-fashioned face-to-face visits when you do better, especially proactive care coordination and a shared plan of care. However, as David Ming then points out, and if you look at the literature on children with medical complexity, their utilization varies over time. So there's an element of regression to the mean. There are times where they flare and then they kind of settle down. And so I think, Rhonda, for those organizations that really are profoundly anchored to fee-for-service, it's going to be really tough to make the case that care coordination matters. However, if you look at family experience, if you say, if we're not filling beds with kids that are getting unplanned readmissions that were preventable, we should be able to fill them with other things. And some of that could be some of the ongoing COVID, and then eventually the post-COVID utilization. There is no lack of children in the world, much less the US, that are going to have special health care needs for where we are right now. So value-based care is really important. And Stacy, I think your articulation of what does care coordination look like is really, really important. And then Andy Carpinelli, who I am thrilled to say called you out, Stacy, as being her chief resident. That is so cool. But I just want to raise this issue is what happens if you're starting from scratch? Is there a better model? I know the answer to that one. And the answer is the jury is still out. So I want to encourage everybody in this Academy, take what Dr. Cook just shared. Let's now bring it into your respective work groups. We'll circle back, but for the next 6 months of this Academy, at least, what are the elements of high value care? Where is the equity? Are we measuring it? And what is the financial value stream that we can identify to sustain this kind of work? If anybody thinks that you're going to take kids with medical complexity and they never need another procedure, it ain't happening. That they're never going to need to get admitted, it ain't happening. So we're not necessarily trying to reduce utilization. We're trying to reduce low value utilization. So I think it's easy to say for me, Stacy, that you did just hit a walk-off grand slam. And for the people in the chat, I think they would agree. So Heather, thank you for letting me wax a little bit poetic here, but that was such an incredible discussion and the chat was robust. So tell us where we need to go.
Thank you so much. So hang on, I'm just going to go to our next slide. So we are now going to go off into our workshops. So the moment we've been waiting for it, you should be able to go down to the bottom of your screen and select the option that says join a breakout group. It should then open up 4 different groups by these titles that you see here on the screen. Your team name is corresponding to which group you selected during our pre-survey. So please try to go down to the bottom, hit join a breakout, and go ahead and join the group that your team has been assigned to. If there's anyone here from North Carolina and Florida, we did not have an assignment for you guys yet. So I'm hoping, feel free to turn on your camera and mic and decide which group you would like to go to. And you can either self-select or we can help place you if you're having any issues with your Zoom. I will stay in this room for a few minutes as well, and then I'm going to head off to the measurement tool group. But if anyone's having trouble, you let us know.